Hello, welcome to week 7 content session. This is for NU 621 Advanced Pathophysiology. My name is Dr. Christy Burks. We're going to get started. This is our final content session for this term. All right. So as we read these chapters, remember chapter 24, there are specific pages that you'll be looking at, specifically pages 753 to 758. So additionally, we are looking at chapter 26, which is that alterations of the male reproductive system. And then we're going to be looking at chapter 37, structure and function of the renal and urologic systems, and then chapter 38, which is the alterations of renal and urinary tract function. So some of the topics that we're covering this week include chronic and acute kidney injury or chronic kidney disease, nephrotic versus nephritic syndrome. We'll be looking at pyelonephritis, overactive bladder syndrome, urinary tract infections, and then some of the male reproductive conditions that we see. So getting started, let's review quickly just the general anatomic and functions of the kidneys. So when we look at the kidneys, they are like a filtering system for your body. They work hard to remove those waste products and extra water from your blood. This waste gets turned into urine that travels down through tubes called the ureters into your bladder. And the kidneys also help control blood pressure and make hormones that keep your body or your bones and your blood healthy. So without kidneys doing their important job of cleaning your blood, those harmful waste would actually build up in your body and make you very sick. So making sure that you're drinking plenty of water to kind of help your kidneys function properly is definitely of importance. Looking at the anatomical locations, the kidneys are paired structures that lie bilaterally between the 12th thoracic and 3rd lumbar vertebrae. And the ureters extend from the renal pelvis to the posterior wall of the bladder, which the urine flows through the ureters by means of peristaltic contraction of the ureteral muscles. So the bladder, which is able to accumulate urine, and when it reaches approximately 250 to 300 mLs, those mechanoreceptors respond to that stretching of that tissue and actually stimulate the action of urinating, and that micturition of reflex is what that's called. And then we have the renal blood flows, which it flows at approximately 1,000 to 1,200 milliliters per minute. And that's about 20 to 25% of the cardiac output, if you think about it. So blood flow through the glomerular capillaries is maintained at a constant rate. So despite a wide range of arterial pressures, which is that autoregulation. Now, autoregulation of the renal blood flow, the RBF, and sympathetic neural regulation of vasoconstriction maintain a constant glomerular filtration rate. And that's what we look at as the GFR. So the major function of the nephron is the urine formation. So that's something to remember. And this involves the process of the glomerular filtration, tubular reabsorption, and tubular secretion and excretion. So when the kidneys actually secrete or they activate a number of hormones that have systemic effects. So if we look at one, which is very important, that vitamin D. So vitamin D3 and your erythropoietin, which stimulates that erythropoiesis when hypoxia is definitely present. So now if we think about disorders or diseases of the kidney, like in the urinary tract system and bladder, so we're going to progress into that. So thinking of the urinary tract obstruction, which refers to any blockage that impedes that normal flow of urine along the urinary tract. So it can occur at any level. So that means the kidneys, the ureters, the bladder, the urethra. The key anatomic features include dilation and increased pressure proximal to the obstruction site, which can actually lead to that hydronephrosis, and which is the swelling of the kidney if severe enough. And functionally, obstruction causes urine stasis, and that increases the risk of urinary tract infections. It also compromises the kidney function by raising pressure in the renal collecting system. So over time, chronic obstruction can cause permanent kidney damage from increased back pressure. So the severity definitely depends on the degree and the duration of the obstruction, as well as the level that it occurs on. Now we'll go into some other things later on in this presentation as well. The first thing that we're going to stop and talk about is overactive bladder syndrome, or OAB. OAB is a condition characterized by sudden urge to urinate that is difficult to control. So some of the main symptoms that we see in our patients that suffer from this include urinary urgency, increased frequency of urination, and nocturia, which is waking up multiple times at night to urinate. So some people with OAB may actually also experience that urge incontinence, which is basically leakage of urine after feeling a strong urge to urinate. OAB occurs when the bladder muscle contracts involuntarily, specifically that detrusor muscle, which forms the muscular wall of the urinary bladder, and it's the primary cause of overactive bladder syndrome. And that detrusor overactivity leads to those symptoms that we see in OAB. So this can happen without any underlying infection or other identifiable cause. So in OAB, remember that detrusor muscle contracts spontaneously and involuntarily during that storage phase, even when the bladder is not full. So this results in that sudden, strong urge to urinate and difficulty in delaying urination. Now, when we look at risk factors, that includes aging, obesity can cause or increase that risk for it, neurological disorders, some pelvic surgeries, and certainly medications can actually, there's some medications that can cause this or lead to it or increase your chance for it. So untreated OAB can actually negatively impact quality of life and actually leads to issues like sleep disturbance, skin irritation, and definitely social isolation because, for fear of it happening outside the home or near a bathroom. So the next thing we're going to look at is cystitis, which is an inflammation of the bladder and usually caused by a bacterial infection. And that's usually. So the main symptoms include frequent and urgent need to urinate, pain or burning during urination. Sometimes they have cloudy or bloody urine, and pelvic discomfort as well. Now, cystitis often results from that bacteria actually entering the urethra and traveling into the bladder. So risk factors include improper wiping after using the toilet, sexual activity, the use of spermicides or diaphragms, structural abnormalities in the urinary tract, and then conditions that may impair immune function. So definitely prompt treatment with antibiotics is important to clear the infection and allow the inflamed bladder to heal. Drinking plenty of fluids and using a heating pad can actually provide some symptom relief during cystitis flare-ups, and some people are more prone to these. If cystitis refers to inflammation of the bladder, it's usually caused by that bacteria infection. And that's something that we do need to make sure that we are testing for and that they show certain signs and symptoms. So that way we're not over treating with antibiotics. Now, in contrast, we have interstitial cystitis, or IC, and this is a chronic condition characterized by bladder pain and inflammation without an identifiable infection. So where we see cystitis often has an acute onset with symptoms like that painful urination, urgency, and frequency that resolve after treatment of that infection. IC, or interstitial cystitis symptoms, are similar but more persistent with no clear inciting cause. So additionally, that IC involves inflammation throughout their entire urinary tract, not just in the bladder lining. While cystitis is treated with antibiotics, IC has no cure and is managed through various therapies to help relieve those symptoms. That chronic inflammation persistent or present in interstitial cystitis, like the bladder pain, or it's often called bladder pain syndrome. So IC or BPS is thought to contribute to the disruption of the GAG layer that protects the bladder mucosa. So the inflammatory process in IC involves that mast cell activation, which contributes to the neurogenic inflammation and pain signaling through the release of those inflammatory mediators like that histamine, leukotrienes, and cytokines. And this increased sensory nerve sensitivity and altered uroepithelial permeability. This deranges the GAG layer, making the bladder lining more susceptible to penetration by potentially noxious substances in the urine. So making sure, just thinking about that process, the loss of this protective barrier actually allows urine components to come in direct contact with the bladder wall. And that's the perpetuating inflammation and symptoms like pain and urgency. The next thing we're going to talk about is nephrolithiasis, or simply kidney stones or renal calculi. The primary pathophysiology behind nephrolithiasis is that supersaturation, which is the presence of a higher concentration of solute or salt within a solvent or urine that can be dissolved. Okay. So of the urine with these crystal forming substances like calcium, oxalate, uric acid, and cystine. So when the concentration of these solutes, okay, that salt exceeds the solubility limits in the urine, they precipitate out and form crystals that can actually aggregate into stones. So supersaturation is essential for stone formation, though other factors like urinary pH, presence of inhibitors or promoters, and other things can also play a role. They can form in the urinary tract, particularly in the kidneys or ureters and or the bladder. And these stones can definitely cause obstructions and severe pain when passing through the urinary system. The main types of kidney stones that we see, or we're just going to talk about some, include calcium oxalate. We have calcium phosphate stones, uric acid, and then even cystine stones. We're going to look at a few more. And I've got some examples from our textbook for visuals. But the risk factors for developing nephrolithiasis include dehydration, dietary factors, metabolic disorders, and even certain medical conditions and sometimes medications. So treatment aims to manage that pain and promote that stone passage, prevent reoccurrence, and then address that underlying cause of those kidney stones. I will tell you, just in the past, taking care of patients with nephrolithiasis, or it's probably one of, I think, I've never had one, but I've seen like I said, taking care of patients, and it can be one of those top painful things, right up there, I think, with pancreatitis. And so just something to consider with those patients. A lot of times when they come in with that severe pain and they have to be admitted, to go to surgery or something to help break that stone up or place a stent, you see those patients, the pain is so bad, it's causing nausea, vomiting, and they're just miserable. Okay, so now we're going to look at those different types of kidney stones that we talked about. The first being the calcium stones, which the calcium oxalate and calcium phosphate. So this first image is from, and all of these images thereafter are from the table 38.1 in the textbook, which provides that information and images of these different types of stones that we're looking at. The next one is, I believe, uric acid stones, and then we have the magnesium ammonium phosphate stones. So I don't think they had the picture. Maybe the picture on the uric acid stones were on the previous one, but anyway. So the next one is, oh, here's the uric acid. Sorry, they're out of order. So you can definitely see the different types and why this could be painful for sure. I think the last one I have is the cystine stones. And then of course you have unknown or other types of stones that can be there too. And then they have a a stone that they call Indeniver something stone, and that's related to certain types of medications that can cause those stones as well. So we look at calcium stones because they are the most common type, accounting for around, according to the textbook, about 80% of all kidney stones. And then you have uric acid and struvite stones, which are also relatively common as well. So important patient education for kidney stones includes, increasing, we talked about increasing fluid intake to produce 2 to 3 liters of urine per day, and that helps flush out the urinary system. You might highlight what type of fluid they're taking, so talk to your patients about what kind of intake, fluid intake they're, taking, whether it's caffeine or tea, soda, or water, something specifically. We need to make sure that they're drinking the appropriate types of fluids. Modifying their diet based on stone types. So I'll show you another image that talks about the eating plans for it, or what types of foods may lead to different stone types. So if you think about limiting your oxalate rich foods for those calcium oxalate stones, also maintaining a healthy weight and exercising regularly. I feel like that can apply to about every condition there is. Avoiding excessive intake of vitamin C supplements, which can actually increase oxalate levels. So it's not so much just making sure that, because I had a friend once that every time before she went on vacation, she would take such a large amount of vitamin C. I have no clue why she was doing this, but and then she'd develop kidney stones, and she was actually taking way too much vitamin C, and taking prescribed medications like thiazide diuretics to help control that hypercalciuria. Recognizing signs of stone passage like that severe pain, nausea, and even blood in the urine. And then definitely seeking prompt medical attention if unable to pass those stones or having recurrent infections. Because remember, those stones can also cause that obstruction, which leads to that backup of urine, which can lead to the infection as well, and or hydronephrosis, where they have the swelling of the kidneys and it starts to impact their actual kidney function. So the key is empowering our patients with that knowledge about lifestyle changes, dietary modifications, and compliance with treatment plans to help reduce those risks of future stone formation. Other things you might consider that increase, for example, risk of the calcium oxalate stone formation and that we see in nephrolithiasis, for example, could be the hypercalciuria, which is that excessive urinary calcium excretion, and that's due to increased intestinal absorption, hyperparathyroidism, or even bone demineralization. We see low urine citrate levels, and as citrate normally binds to calcium and prevents stone formation. Again, we talked about dehydration and that low urine volume, which allows stone forming substances to become concentrated. Acidic urine pH, which can actually promote the precipitation of calcium oxalate crystals. And then, of course, deficiencies in natural inhibitors of crystallization like magnesium citrate, and then the TAM horsefall protein. And then, of course, you have some certain medical conditions like inflammatory bowel disease, obesity, diabetes can also increase those chances or that risk of developing calcium oxalate stones. All right. Just to talk briefly a little bit more about struvite stones, some of the main risk factors associated with those struvite stones include urinary tract infections caused by specifically urease producing bacteria like Proteus, Klebsiella, or Pseudomonas species. These bacteria raise the urine pH and allow struvite crystals to form. Conditions that impair complete bladder emptying, such as neurogenic bladder or chronic urinary catheterization, is something to consider, which these can actually promote that bacterial growth as well. And then unfortunately, just female gender. So as women, we have a higher risk for UTIs. Presence of foreign bodies in the urinary tract, like kidney stones or urinary catheters, which can act as as a risk for those struvite stone formation and assist with that. So chronic kidney disease or metabolic disorders that increase ammonia production can increase that risk. And then malnutrition or high intake of magnesium ammonia phosphate. So definitely we want to make sure to preventing and promptly treating those UTIs, which is crucial for reducing that risk of those struvite stone developments as well. Now, this next image is just a clip from the website that I will share. I believe it's on the, I'll make sure it is, that it's on the your announcement with your additional resources, the synchronous session schedule and links announcement for week 7. It's got this link there, but it's the National Institute of Diabetes and Digestive and Kidney Disease. It has a section on kidney stones with a section on eating, dieting, and nutrition for kidney stones. So I thought it was a pretty good resource, especially if you're trying to educate your patients and provide them with more knowledge about their disease process or their conditions that they're developing. And I believe this last image I pulled from one of the resources from the library under the 3 Ps. I know we've talked about that several times, but it's just another image that shows a kidney with hydronephrosis and that staghorn type calculi. So or that kidney, stone. So I thought it was a pretty good image just to look at what that can do to our kidney. All right, next we're going to get into acute kidney injury and versus chronic kidney disease, okay? So when we talk about acute kidney injury or AKI, this is a sudden decline in kidney function characterized by an accumulation of those waste products and decreased urine output. The primary reason for that decreased urine output in AKI is that renal hypoperfusion and ischemia injury to kidneys, where that decreased renal blood flow leading to that reduced GFR. So this can occur due to various different causes like hypovolemia, hypotension, sepsis, or obstruction to the urine flow, like we talked about with the stones that we see. The ischemic injury triggers an inflammatory response that damages those renal tubules and glomuli, impairing their ability to filter waste and produce urine. So this results in that decreased urine output, which is a protective mechanism to prevent further injury by reducing the kidney's workload. However, persistent with that decreased urine output can lead to a dangerous buildup of fluid and waste products in the body. So AKI is classified according to the underlying pathophysiology. So we have a couple different. So first is pre-renal AKI, which is caused by decreased blood flow and perfusion to the kidneys, often caused by conditions like hypovolemia, which leads to that decreased renal perfusion. We see this sometimes in heart failure or even renal artery stenosis, okay? And the textbook actually has, this is where I'm pulling the images of the chart because it's showing you the pre-renal AKI, and then it goes into more details of possible causes, okay? The next one or part of that chart includes intrinsic or intrarenal AKI. And this involves a direct injury to the kidney tissues and structures, such as from toxins, infections, or even autoimmune disorders. So the pathophysiological mechanism behind acute tubular necrosis related to intrinsic or intrarenal acute kidney injury involves direct injury to the renal parenchyma and tubular cells. Again, you can look through this a little bit closer and it's got more information there as well. The last one we look at is post-renal AKI, which results from an obstruction to urine flow from the kidneys, like kidney stones or even tumors blocking the ureters or urethra. Now, this last image, again, is just a visual, another visual from one of the resources from the library, those 3 Ps, providing the information in a different way. It's just it breaks it down in a little bit differently. So I just like to show it as well. Now, the stages of acute kidney injury, according to the Kidney disease, according to kidney disease improving global outcomes, or KDIGO classification. We have stage 1, which is increase in that serum creatinine by greater than or equal to that 0.3 within about 48 hours, or increase to greater than or equal to 1.5 to 1.9 times their baseline. We have stage 2, which increases that serum creatinine to 2.0 to 2.9 times baseline. And then stage 3, where we see an increase in serum creatinine to greater than or equal to 3 times their baseline, or increase of greater than or equal to 4, or initiation of renal replacement therapy. So the staging system categorizes the severity of the AKI based on changes in the serum creatinine levels from baseline, and accounts for patients like on dialysis. Higher stages indicate more severe kidney injury and worse outcomes. So what that means is somebody with chronic kidney disease can actually, they have a baseline when we see chronic kidney disease with the GFR and their creatinine levels, but they can actually have acute kidney injury on top of chronic kidney disease. So therefore, our goal is to get them back to their baseline, which may still be in that chronic kidney disease level, but we definitely don't want it to worsen their chronic kidney disease. Okay. We talked about that. Go over a little bit more. Okay, another thing to consider, or we need to talk about, is how AKI, like ATN, represents an abrupt decline in that kidney function, and this can happen over hours to even over days. So whereas that chronic kidney disease, or CKD, is a gradual loss of function over months to even years. However, AKI can actually lead to chronic kidney disease progression if the kidneys do not recover fully. And that's what I was talking about, if they have AKI on top, secondary to that chronic kidney disease. The progression of the kidneys, it's vital for them to recover fully to get back to that baseline that we were talking about. An episode of AKI superimposed on that pre-existing chronic kidney disease also hastens the decline towards that end-stage renal disease. And that's the prompt treatment of that underlying cause is very essential to help allow the tubular cell recovery and prevent that permanent nephron loss that we can see in AKI. Now, nephrotoxic injury is a major cause of that ATN, or acute tubular necrosis. So certain drugs, we see like contrast dyes, we have to be very careful with that. NSAIDs can even accumulate in and directly damage the epithelial cells of the renal tubules, especially the proximal convoluted tubules. So the necrosis or death of these tubular cells is often uniform along the nephron due to the toxic insult. So nephrotoxins include oxidative stress, inflammation, and even obstructive cast formation, leading to that ischemic injury and tubular cell death. This results in the clinical manifestations of ATN and acute kidney injury, with the end result is acute tubular cell death and sloughing, leading to that impaired reabsorption and urinary concentration ability, ultimately causing a rapid decline in that renal function. So that is why it is very important. So now the pathophysiology or the pathogenesis of chronic kidney disease, or CKD, involves definitely a complex interplay of factors that lead to progressive nephron loss and renal scarring. So initially, when some nephrons are damaged, the remaining healthy nephrons undergo that compensatory hyperfiltration to maintain overall GFR, or glomerular filtration rate. However, this hyperfiltration leads to increased intraglomerular pressure, causing further glomerular injury and proteinuria. The proteinuria contributes to that tubule interstitial inflammation, fibrosis, and more nephron loss, perpetuating a vicious cycle of that. So your angiotensin 2 activity also plays a very key role by causing efferent arterial vasoconstriction, promoting glomerular hypertension and hyperfiltration. So the most common cause of chronic kidney disease we see is in diabetes mellitus, as seen with our diabetic nephropathy, where chronic hyperglycemia actually leads to glomerular hyperfiltration, that protein glycation, and progressive glomerular sclerosis. Other causes include chronic glomerulonephritis, hypertension, and even autoimmune disorders like lupus nephritis. So the increased renin angiotensin aldosterone system, or RAS, activity plays a central role in the pathogenesis of hypertension and chronic kidney disease. As kidney function declines, there's a decrease in that renal blood flow and perfusion. And this is what triggers the release of that renin from the juxtagular glomerular cells in the kidneys. And renin initiates that RAS cascade, leading to the formation of angiotensin 2. Angiotensin 2 causes that vasoconstriction of the efferent arterioles, increasing that intraglomerular pressure and that systemic blood pressure. Now, additionally, angiotensin 2 stimulates the release of aldosterone from the adrenal glands, and aldosterone promotes the sodium and water reabsorption in the distal nephron, and that further increasing blood volume and blood pressure. So the cycle of RAS activation and vasoconstriction and fluid retention perpetuates hypertension in our CKD patients, or chronic kidney disease patients, and this leading to further kidney damage and a vicious cycle of worsening renal function and uncontrolled hypertension. Now, in chronic kidney disease, when some of those nephrons are damaged, the remaining healthy nephrons undergo, again, that hyperfiltration to maintain that overall glomerular filtration rate. So that is something to remember. Now, understanding GFR level can actually tell you help tell you the stage of the kidney disease for chronic kidney disease. So thinking of stage 1, where the kidney damage with a normal GFR is usually greater than or equal to 90. Stage 2, which is a mild decrease in GFR, we tend to see it between 60 to 89. And then stage 3, we have A and B. So stage 3A is a mild to moderate decrease in GFR, and we see it around 45 to 59. Whereas stage 3B is that moderate to severe decrease in GFR, and we see 30 to 44 as a result. And then stage 4, which is that severe decrease in GFR, is 15 to 29. And then finally, stage 5, or end-stage renal disease, is anything less than 15. And this typically is requiring dialysis or transplant. Now, the lower the GFR, the more severe the kidney dysfunction. So that is something to consider whenever you're looking and assessing those labs. Now, chronic kidney disease can lead to several different complications, and just a few of those we're going to talk about real quick. One includes the fluid and electrolyte imbalances. So, of course, we see hypercalcemia, metabolic acidosis. We see anemia, and that's due to the decreased erythropoietin production. We see bone and mineral disorders, so hypocalcemia, renal osteodystrophy. We have cardiovascular complications. We talked about hypertension. Heart failure is another one to consider, and then pericarditis. Neurological complications, and we can see encephalopathy or peripheral neuropathy as well. We do see an increased risk of infections due to their impaired immune system. We see GI disturbances or complications like nausea, vomiting, and even bleeding, which we've talked about in our other weeks when we were talking about GI. In our endocrine disorders that we talked about, we have the glucose intolerance or hypogonadism, malnutrition and wasting due to decreased appetite and nutrient losses. And then finally, psychosocial issues. So, you think of the lifestyle changes, the social impact. Um, we see depression, anxiety, and even sleep disturbances. So that is something to consider whenever you are developing a plan of care for these patients. So as chronic kidney disease progresses, these complications become more severe and life-threatening, and this highlights the importance of that early detection and management and potential kidney replacement therapy. So that is something to be considered. I want to make sure that I go over. So another thing I wanted to talk about in chronic kidney disease is the impaired renal function, which leads to that decreased activation of vitamin D, okay, resulting in reduced intestinal absorption of calcium, and this causes hypocalcemia or low serum calcium levels. The hypocalcemia actually triggers the increased secretion of the parathyroid hormone, that PTH, by the parathyroid glands. And this is that compensatory mechanism known as secondary hyperparathyroidism. And that elevated PTH actually helps mobilize calcium from bones to normalize serum calcium levels. So that is something to remember. Also, the primary cause of uremic syndrome seen in our chronic kidney disease patients is the accumulation of nitrogenesis waste products like urea, creatinine, and other uremic toxins in the blood. And this is due to the kidney's inability to filter or excrete them effectively. So this buildup of uremic toxins leads to various symptoms like nausea, vomiting, and that anorexia, fatigue, and even neurological disturbances, collectively termed as the uremic syndrome. Now we're going to go into nephrotic syndrome versus nephritic syndrome. So these are two distinct kidney disorders with different underlying pathologies and clinical presentations. So that is something that you need to kind of compare and contrast and make sure that you understand. So nephrotic syndrome primarily affects the glomerular filtration barrier, while nephritic syndrome involves the glomerular inflammation and injury. Nephrotic syndrome is characterized by massive proteinuria greater than 3.5 grams in a day, hypoalbuminemia and hyperlipidemia and edema. It results from increased permeability of the glomerular capillary membrane, allowing excessive protein loss in the urine. And the primary cause is minimal change disease. So, but it also can occur due to conditions like diabetic nephropathy or that lupus nephritis that we talked about earlier. Now, in contrast, that nephritic syndrome involves inflammation and damage to the glomeruli, causing hematuria or that blood in the urine, proteinuria, hypertension, and that reduced GFR or glomerular filtration rate. It's often caused by immune mediated disorders like post streptococcal glomerular nephritis or IgA nephropathy, or even rapidly progressive glomerulonephritis. So remember, the key differences are the presence of the hematuria and hypertension in nephritic syndrome, and the predominance of edema and hyperlipidemia in nephrotic syndrome. Nephritic syndrome and glomerulonephritis is what can lead to a decreased urine output, hematuria, that blood in the urine, and hypertension due to that underlying inflammation and damage to the glomeruli. The inflammatory process causes leakage of the red blood cells into the urine, resulting in that hematuria. As the glomeruli become damaged, the filtration capacity of the kidneys decrease, leading to the decreased urine or oliguria. The impaired filtration also causes retention of fluids and waste products, contributing to the hypertension. Additionally, the release of the inflammatory mediators can further exacerbate hypertension by causing vasoconstriction and activation of that RAS. Now we have glomerulonephritis, which refers to inflammation of the glomeruli, those tiny filters in the kidneys, and it can be caused by various different factors, including immune system disorders, infections, or even other conditions that trigger that inflammatory response. So common manifestations include proteinuria, hematuria, white blood cells, and casts in the urine, and then reduced glomerular filtration rate. Glomerulonephritis can lead to progressive kidney damage if it's left untreated. So treatment aims to address the underlying cause and suppress the immune response and manage complications like the edema and hypertension. Now, the primary immune mechanism in post-infectious glomerulonephritis involves the deposits of the circulating antigen antibody complexes within the glomeruli. So during an infection, we think the immune system produces those antibodies against the infectious agent. So these antibodies can form complexes with the antigens and get deposited in the glomeruli, initiating that inflammatory response. Those deposited immune complexes activate that complement system, leading to chemotaxis and neutrophils and macrophages. This results in the release of the inflammatory mediators like our oxidants, protease, and cytokines, causing further glomerular injury and proteinuria. The immune complex deposition triggers a cascade of events that ultimately damages the glomerular filtration membrane. So the rapidly progressive glomerulonephritis, or RPGN, is severe form of the glomerulonephritis that develops acutely over weeks or months. It's characterized by presence of that crescent-shaped cells in the Bowman capsule. So patients become quite ill quickly, experiencing symptoms of kidney impairment like fluid overload, hypertension, oliguria, electrolyte imbalances, and uremic symptoms. So RPGN often progresses to end-stage renal or end-stage kidney disease despite any treatment. The main differences between rapidly that RPGN and general glomerulonephritis is the rate of progression and severity. So just remembering that RPGN is that rapidly worsening from that develops over weeks and months, often leading to that end stage, okay, despite any treatment that we give them. Oh, pardon me. All right. Next, we're going to look at UTIs. And in order to talk about UTIs, we also need to define asymptomatic bacteria, which is evident in some who are colonized with bacteria that does not cause an infection. So some of our patients, we identify, it's important that we identify when to treat a patient. So you need to evaluate the symptoms the patient is having. Some hospitals will actually not do a urinalysis unless certain symptoms or criteria are met. And this helps prevent treatment with or over treatment of antibiotics when they are not needed. This increases, if we do that, if we're treating everything that are like all these asymptomatic bacteria, it increases the opportunity for those antibiotic resistant bacteria to grow. So this is why it's important. So this link is located in the synchronous session schedule and links announcement. It's from the National Healthcare Safety Network, or NHSN, from the January 2024 site, which is the most widely utilized healthcare associated infection, or HAI, tracking system. So the link will actually take you to the NHSN site for UTIs, catheter, specifically CAUTIs, or catheter associated urinary tract infection, and non-catheter associated UTIs events. So take a look at their flow chart for identifying symptomatic UTIs versus asymptomatic UTIs. I know it's very small in this. That's why I provide the link there in our extra resources for you to review, are additional, and they are optional, but I think it's interesting. So most of the time bacteria is washed out of the urethra, and the textbook talks about host defense mechanisms, and UTI, which describes how the body naturally attempts to prevent UTIs from occurring. So the pathogenesis of UTIs involves the invasion of urinary tract by uropathogenic bacteria. Most commonly we see is E. coli, and E. coli possesses that virulence factors like adhesions. For example, that type 1 fimbriae that allow it to bind to the uroepithelial cells and resist being flushed out during urination. So E. coli has the ability to adhere to the uroepithelial cells lining the urinary tract via adhesive fimbriae or pili on its surface. So this bacterial adherence initiates an inflammatory response with the recruitment of neutrophils and release of cytokines. The inflammation triggered by infection and or the irritation of the bladder lining, that cystitis, leads to urgency, frequency, dysuria, and those are those key clinical manifestations of those lower UTIs. So urgency and frequency arise from the bladder's increased sensitivity to those small volumes of urine due to inflammation. And then we see dysuria, which occurs as the inflamed urethra is further irritated during the migration. In severe or ascending UTIs, the inflammatory process can extend up to the kidneys, which we call pyelonephritis, potentially causing fever, flank pain, nausea, and vomiting. So complications like bacteremia or sepsis can actually occur if the infection disseminates systemically. So risk factors for UTI includes instrumentation, urinary stasis, that reflux, and impaired immunity. Now, talking about pyelonephritis, we look at acute versus chronic, where acute pyelonephritis is typically caused by ascending bacterial infection from our bladder, often involving that uropathogenic E. coli that we talked about. Risk factors include urinary tract obstruction, vesicoureteral reflux, or allowing that urine backflow, recent instrumentation, meaning catheterization or cystoscopies, think of things like that, and impaired immunity. So the leading mechanism is that bacterial accession along the ureters or that lower urinary tract, most commonly from the bladder into the kidneys, causing an inflammatory response. So we talked about the uropathogenic bacteria like E. coli, which colonizes the bladder and then travels up the ureters, gaining access to the renal pelvis and other structures. The ascending route of infection from the bladder to the kidneys is the leading mechanism behind acute pyelonephritis. Now, when we think about chronic pyelonephritis, this usually results from recurrent acute episodes or persistent kidney infection due to an underlying structural abnormality like obstruction, reflux, or urinary stasis. So the hallmark pathological feature of chronic pyelonephritis is that tubulous interstitial scarring and atrophy. The persistence or recurrent infection and inflammation actually leads to progressive destruction and scarring of the renal tubules surrounding interstitial tissues. So over time, this results in that loss of function, nephron units, and replacement with the fibrous scar tissue. Tubular atrophy and interstitial fibrosis are characteristic findings on biopsies in chronic pyelonephritis. So our risk factors include congenital urinary tract abnormalities, kidney stones, as we've talked about earlier in this presentation. Neurogenic bladder can be a risk factor, diabetes, and then of course, chronic indwelling catheters. And basically that's just a pathway leading to it. If you think about the catheter, the persistent bacterial presence and inflammatory response lead to that renal scarring and progressive damage over time. Now, the first photo, another photo, and this is again from one of those resources from the 3Ps from the library you can find. I just thought it showed a little bit better. The first photo, you can see there's lots of reddish areas that indicate that scarring. Whereas in the second photo, you can see the severe dilation of the calces as well as the atrophy and scarring of the cortex. All right, we're going to briefly talk about some of the male reproductive issues from the one chapter that has some specific pages that we are going to read. The first being hydrocele. This is an abnormal accumulation of fluid between the layers of the tunic vaginalis, the membrane surrounding the testicle. So the primary feature is a painless swelling or enlargement of the scrotum due to the fluid collection. Although I will say I've cared for males that had this, and it can be painful. It just depends on the patient and the situation. Hydroceles can be congenital, caused by failure of the processus vaginalis to close after testicular descent, or acquired later in life due to conditions like infection, trauma, or even malignancy leading to that fluid accumulation. And I think that's more of the patients, that population that I took care of. It was always an infection, trauma, or a malignancy that led to this. The next is called a varocele. And this is an abnormal dilation and tortuosity of the pampiniform venous plexus that drains blood from the testicles. It most commonly affects the left side due to the anatomical differences, where the left testicular vein drains into the higher pressure renal vein, while the right side actually drains into the lower pressure of the inferior vena cava. The main complication of this is male infertility. The increased blood pooling and elevated temperatures can impair the spermatogenesis, leading to those low sperm counts, decreased motility, and abnormal morphology. Large varicoceles can also cause testicular atrophy, hormonal changes like decreased testosterone, and even chronic testicular pain in some cases. Next is priapism, which is persistent, painful erection lasting more than 4 hours without any sexual stimulation. So ischemic priapism is the most common type, and this is caused by venous outflow obstruction and lack of oxygen supply to the penis. Now, the primary mechanism is a compartment syndrome-like process where lack of venous drainage or impaired arterial inflow. This leads to that stagnant, deoxygenated blood pooling in the corpora cavernosa. This causes the ischemia. The ischemia causes acidosis, edema, and eventually irreversible smooth muscle damage if not treated properly and promptly. The most common hematological condition associated with ischemic priapism is sickle cell disease, because in sickle cell disease, those sickled red blood cells can actually obstruct venous outflow from that corpora cavernosa. And that precipitates a vicious cycle of that stasis, acidosis, and then further sickling. All right. Peyernie's disease is characterized, or PD is characterized by the formation of fibrosis plaques within the tunica albuginea of the corpora cavernosa. This most commonly impacted factor is repeated microtrauma or injury to the penis, which initiates abnormal wound healing process. Now, the tunica albuginea plays a central role in the progression of Peyernie's disease, as the plaques from within this fibrous sheath surrounding the corpora cavernosa, as the inelastic plaques develop in the tunica albuginea, it leads to that penile curvature and deformity and during erections due to the asymmetric constraints and or on the expandability of the corpora cavernosa. I think I have one more. Okay, so the last well, we've got two more that we're going to talk about. Phimosis is a condition where the foreskin cannot be retracted over the glans penis. So the primary pathophysiology of phimosis is the inability to retract the foreskin due to perpetual tightening. So in adults, the most common cause is poor hygiene and or chronic infections. A chronic inflammatory skin condition, one called lichen sclerosus, is that a skin condition or chronic inflammatory skin condition that can lead to scarring and phimosis. Chronic balanitis, which is inflammation of the glans penis, can also lead to scarring as well. Now, paraphimosis is the opposite. And this is where the foreskin is retracted behind the glans and cannot be reduced. So the key difference is that in phimosis, the foreskin cannot be retracted, while paraphimosis, it is retracted and then it gets stuck behind the glans. An untreated paraphimosis can actually lead to complications like ischemia, necrosis, and autoamputation of the glans penis due to the constricting foreskin cutting off blood supply. So this disordered collagen deposition, their deposition and fibrosis within the tunica albuginea is the hallmark pathological process driving the progression of PD. So one example of the untreated paraphimosis where we saw the foreskin was retracted and it got stuck or it was left. It wasn't pulled back. So if you ever, somebody ever showed you how to put a catheter in, they say, if you pull it back, put it back. One example I saw in the last 20 years was this was done. It was pulled back for catheter insertion and then they forgot to put it back. And it actually caused ischemic necrosis and the patient had to be taken to surgery. And it was pretty severe. So that is definitely something to be concerned about and to make sure